Everybody. I'm in the very unnerving position of not being able to see anyone at all. But my name's Eleanor Rofe. I'm Director of Public Health at Trafford, and I'm really very honoured to be asked to chair today's event. We don't have a long time, but we've got a really amazing and packed agenda. We are recording the event, so people will be able to see that afterwards. And please do mute your microphone. There is a chat function, so do put in the chat anything that you want to say. We're hoping to have time for some Q&As, but this is the first of our new GM Falls collaboration on evidence-based falls prevention and strength and balance programs. I think, especially coming out of the pandemic, really trying to focus on falls prevention. It is the perfect time for us to be doing this work, getting out and people out and about, getting more confidence back, and particularly among our older population, is absolutely critical if we are going to start redressing some of the absolutely dreadful impacts that there have been from COVID on our older population. And I think, that fear of COVID, and to my own parents, I spend quite a lot of time saying, the things that are likely to kill you are cancer and CVD. And if you don't get out and about, if you don't keep your mental health good, if you don't keep your physical health good, those are the biggest risks to you. And that falls prevention work, anything we can do to prevent falls and to stop the fear of falls, I think is just absolutely, it's always important, but it's really, really important now. So without any more ado, I'm going to hand over to Professor Chris Todd, who is going to use this opportunity to share this good practice on our falls prevention program, tell you about the things that are going on, and really get us started. Thank you very much, Chris.
You're on mute, Chris.
Oh, thank you so much. That's great, isn't it? Great start. After 2 years, still forget to come off mute. Okay, good morning, everyone. Welcome to our event. I'm going to be talking about the Falls Management Exercise Programme, and just quickly going through a few of the challenges and opportunities that we face in Greater Manchester. So if I start with my next slide, as Eleanor said, we're coming out of COVID. We have these activity guidelines from 2019, and many people, older people, were not achieving those activity guidelines. So 150 minutes a week of moderate intensity exercise, or 75 of more vigorous. And of course, that building of strength is very important. But many older people were not fulfilling those activities prior to COVID. Let's see the next slide, please. The proportions of people clearly drops off with age, and there's a little picture in the bottom. There's some work that we've been doing recently, looking at the effects of COVID on activity, and this is just the walking, which obviously doesn't improve strength and balance for falls, but all levels of activity have dropped off during the pandemic. Next slide, please. So what position we are in is that, and I can't go through these slides in any detail, but the big red lines sticking out to the right are people doing nothing. So more people are now doing little or no activity. And the greyer ones out to the left-hand side are those people who were doing activity, or greater amounts of activity before the pandemic, are now doing less. So it drops off 10, 15% in activity levels downwards, and the more people doing less. And this comes from the Public Health England report on the wider impacts of COVID. And the bottom right slide there shows essentially that we're going to see an increase of in the region of 5–8% in older people's falls over the coming years if nothing is done. Something like 250,000 additional falls per year can be expected in England. And that's nationally. Let's remember that here in the Northwest, here in Manchester, we've actually had more time in lockdowns than other parts of the country. So we're going to find even more impact of being locked down and becoming deconditioned amongst our population. So it's time to do something about this. Next slide, please. There's great evidence that falls can be prevented. I hardly need to tell you this, I hope, being the audience you are, that exercise, activity, strength and balance exercises will reduce the rate of falls by 23%, reduce the number of people who fall by 15%, reduce fractures by a quarter or more than a quarter, and reduce the falls requiring medical attention by nearly 40%. And that's evidence from, 23,000 participants in 108 randomized trials. This is strong evidence that exercise does prevent falls, but not all exercise is the same. Let's have the next slide. We've been doing quite a lot of work over the recent couple of years, a few years, in Greater Manchester and beyond. And basically today is the culmination of that work, where we've been looking to see how we can improve the provision of exercise, strength and balance exercise across Greater Manchester. And what was it? A couple of weeks ago, a month ago, gosh, time goes so quickly, there was the launch of the Greater Manchester Fall Prevention Collaborative, and the launch of the Delivering Integration and Reconditioning. And as has already been said, we're at a kind of almost perfect juncture for falls to come right up the agenda and for us to really start to do something to turn back the deconditioning we've seen in our older population and do something about falls prevention. Next slide. So, FaME, falls management exercise, is clearly known to prevent falls. What is FaME? It's a 24-week structured exercise program delivered by postural stability instructors. It's group-based, but individualized, and so an individual's ability. And the important component here is the progression of the exercises. Exercises have got to be challenging, they've got to challenge balance, they've got to improve strength, and they help to regain stepping reactions. And FaME, importantly, has a set of exercises, activities, which teach skills for getting back up off the floor if you end up down there. It increases with difficulty and resistance over time. Delivered properly, FaME will reduce falls by between 26 and 54%. Of course, that depends upon the duration of the exercise activities, the population it's being done with, and fidelity to the program. Next slide. FaME is more than just a falls prevention exercise program. I won't go through all of these things. The headlines there in bold are FaME is associated with increases in habitual physical activity. Increases by 100 to 167 minutes per week by the end of the program. That's really important given the drop that we've seen, halving that we've seen, more or less halving in the amount of physical activity, strength and balance related activity that older people are doing due to the pandemic. I think it was dropped from about 122 minutes to about 74 minutes, if I recall correctly. So really important, we get habitual physical activity improvements. We also get a good return on investments. So for every £1 spent on FaME programs, you'll get between £3 and £50 return. That depends upon quite the way you count it and the way that FaME has been implemented. Next slide. There's lots of evidence and lots of policy support for FaME, right from the beginning of FaME being first published when Dawn Skelton, who's speaking later, was here in Manchester, working here in Manchester in 2005. Then the Department of Health picked it up, recommending it at an early point. Public Health England recommend FaME. It's in the guidelines for NICE. And importantly, 2020 saw the launching of the FaME Implementation Toolkit, which we're going to be talking about more today, which has been endorsed by NICE. This is kind of preview because they're not out yet, but we know that FaME is going to be one of the recommendations in the new forthcoming global World Falls guidelines, which are going to come out probably in October this year. So lots of support for FaME as an exercise program. Please, next one. So what are the opportunities and challenges facing us? We have got the FaME Implementation Toolkit, which we'll be talking about in more detail in a few minutes. It's been endorsed by NICE. It gives you information about how to commission services, service specifications. It gives you information about how to build a business case for commissioners and make sure there's procurement. It's got a series of quality improvement tools involved in it. It's got benefits capture, evaluation and outcome measurement, tells you how to capture the benefits of the program. It's got all sorts of marketing and communications advice, or comms advice, and a series of video stories from participants and commissioners. There's a whole load of video libraries and home exercise booklets to support delivery and support those. So that's an opportunity, the FaME Implementation Toolkit, which is what we're going to be talking about in a minute a bit more. And if we have the next slide, what are the challenges? Well, the challenges are, in essence, things like, what is the essential component of the FaME program? What has absolutely got to be delivered versus what is the overall fidelity to the published FaME program? So what do you actually focus on and make sure you deliver? What we've noticed over time is people tend to deliver it as a seated program rather than standing, because of concerns about the people that are taking part. That's a real challenge, because if done seated, it doesn't provide the level of challenge to actually bring about change. There's been tends to be sometimes a lack of progression and a lack of dose. And we see sometimes, quite often in fact, that rather than being a 24-week program, it's a 15-week program. There's often been missed opportunities in joining up work in the NHS, making sure that community programs connect through to somebody's discharge from hospital, for example, that they actually then followed up in the community and then followed up after the end of their 15 or 24-week program. And there's been
1 minute, Chris.
Yeah, I'm finished now, actually. Missed opportunities for this social connectedness and behavioural change. So those are the missing parts. Those are going to be the challenges. So I think that's the next slide. That's the point where we can now look at the lived experience, and over to our video.
Thank you very much, Chris. Just follow videos, and really such useful stuff there, especially from a commissioning perspective. Lots for me to think about.
Facing forward. Nice steady pace for you.
I started coming to classes in June 2016 after I'd had a stroke in September 2015 on the advice of my physiotherapist.
Are we okay? Yeah. Do we feel like we've worked?
I felt as though I wanted to give something back for all the help that I've had. So I asked Mandy, could I do something to help? I know I'm not physically fit enough to be a volunteer in the classes, and she suggested that I went to do volunteering with her to show people what can be achieved. And the first person we went to see was an old gentleman that hadn't been out of the house for 5 years. By me going and showing them what could be achieved, hopefully we would try to get this gentleman out of the house, you know, and get him to come to the classes, because he was very depressed because he sat in on his own all the time and couldn't get out, you see.
This time put your right hand on the chair.
We realised that there weren't as many men in the programme as there were women, and one way we found really beneficial to overcome this is by engaging the men in home visits. So really what we use it as is a rapport building tool so that we gain their trust so that they're able to access the programme more easily.
Thank you very much indeed for showing that video. I think that really is very inspirational, and especially that the picking up ways of including men and making sure that more men are active in this. I'm going to move straight on, because we are very short of time, to the Bury and Wigan good practice sharing. I'm not sure who's speaking on this. Is this Eleanor? Is this you? And
Yeah,
then Terry?
it's myself.
Lovely, thank you.
My name's Eleanor Reynolds. I work for Wigan Council, part of the Be Well team. I oversee some of our physical activity and weight management programmes, and Terry's here as well, who leads directly on the active ageing programme. Next slide, please. And then next slide. So basically what we'll talk about is how we start off with home exercise and what criteria we use to transition people onto groups. So we do accept people onto our strength and balance programme from a variety of different partners, whether that's clinical, social care, but also through self-referral as well. We start with an asset-based phone conversation, so we discuss people's aspirations, interests and what the offer will entail, and then this is followed up still on the phone by some health screening. We use validated tools and discuss the full history as well. When we decide between ourselves and the participant what is the best activity for them, and how we decide on home exercise is it can be dependent if the referrer states that home exercise is recommended. Sometimes the participant requests a home visit, and this might be due to transport issues they have, confidence in coming out, or accessibility to access the groups. But the instructors also will pick up signs during that initial phone conversation. So if somebody's particularly breathless, or they discuss their ability to carry out daily tasks is difficult, or any other issues arise, then that might decide that the best starting point is a home visit for somebody. Next slide, please. So in week one, we start with that home assessment in the home. It's a chance to start building that rapport, as Christine mentioned in the video that she did as a volunteer. We also clarify the details from the phone assessment, and the instructor also observes how that person mobilises around the property. If required, we'll also look at any social care needs. So the instructors are signed off competent to assess for low-level equipment, but they also might connect into wider support and services if any concerns arise. And also at this point, they'll start introducing a tailored exercise programme. In between visits, the team provides phone calls, and they will do at least a further 2 visits into the home to progress that activity programme, build that person's confidence, and start discussing what that activity journey would look like in the long term. And that tends to happen over 2 to 5 weeks, but not always necessarily so, depending on that person. And then on week 6, we will review that person's progress again back in the house, recomplete those assessment tools, have a discussion of what the next steps would look like, provide any recommendations, and then connect again with services as required. That activity programme in the home could take several forms, and this depends on that initial conversation. It could be more chair-based exercise to start with, using the booklets and bands that have been designed by Later Life Training. We introduce standing exercises. It might be on the first week, it could be as the weeks progress. We also have a pedal loan scheme, which is portable pedals, where we filmed local bike rides so people can access those filmings. We have a variety of different online and digital content we can share with people. And we also have Make Your Move DVDs that have been given to us by GreaterSport. Next slide, please. When we look at somebody transitioning from a home exercise to a group, we do need to see that they're able to transfer independently. They will need to be able to stand supported for a minimum of 30 seconds without excessive sway. We do look at their access to transport. If they don't have that, we will discuss local services, charities, community interest companies that are able to help provide that. We also look at support requirements to access the group. So a lot of our groups have volunteers in, and you saw that with Christine as one of our volunteers, but sometimes somebody might need a family member to support them as well to access that group and complete the exercises. So these are all the things that are discussed. When we restarted the programme and brought all our existing participants back last year, we did use a PSI functional assessment grid. We don't currently use that for every person that accesses the programme, but this is something we are looking to reintroduce again. That might be a useful tool for having a bit more formal criteria into that transition from home visit to group. Next slide, please. So since April 2021, mainly beginning around the autumn time, we've seen 126 people for home visits. 32 are still participating and 33 have completed that programme so far. Of the people that have completed, 26, so that's 79% of the completers, have progressed to a group session. So if people do finish that exercise programme in the home, it is a really good way of getting people into the groups and get started. With non-completers, we have found this is genuine reasons, so it might be inappropriate referrals, it might be about hospitalisation, deterioration and those health conditions. And what we found is because of deconditioning during the pandemic, we're getting more and more of a demand to do home visits rather than the group sessions. And we're also seen to be picking up more in that, because the pressure in the wider system, we might be seeing people earlier in their stage from clinical teams than we did before the pandemic. Next slide, please. And I think this is the last one. So I just wanted to go through a case study so it actually brings it to life how it might actually work. So Zara, one of our instructors, saw a participant who tested positive in January 2021 for COVID and spent 7 months in hospital, including intensive care as part of that. In September, he was referred to ourselves by reablement because of his reduced strength and mobility. He was breathless and still weak and fatigued. So when Zara saw him in the first visit, he managed 3 seated mobility exercises and could only walk 10 steps with the frame. So the first 4 visits focused on seated exercises only, and she also provided the portable pedals, which I mentioned before, so he could do that seated. She then progressed into a few standing exercises, and he now stands for most of his activity. She connected him with other services, including community therapy and early intervention, who provided a grab rail. He also had a stairs assessment, and then Zara did those exercises with him as well as part of a functional programme, and they also provided a temporary ramp for the front door, so he was able to get out and about a bit more. As I said, we worked with some clinical teams and she supported him doing functional exercises, and he now sleeps upstairs, which he didn't do at the beginning of the programme. He goes out of the house and he can walk around with just the 1 stick, so he's progressed completely. After more recently focusing on some of the class elements that we would do in a FaME programme in a group, we have had a chance to build his confidence more and talk about the group sessions, and he has now started a group session with us in the last few weeks. In my previous slides, I did mention that it's a 6-week programme, but obviously this has taken a lot longer, and we do have a lot more flexibility where we can really see progression in somebody, and somebody that is really trying and really would benefit of that continued work. And we've done that with him, and that's been a great success. And that's the last slide. Thank you very much.
Thank you very much for a really very, very inspirational talk. We had one question in the chat about the qualifications and the training that was given. I think the answer was given in the chat, but just in case people can't see the chat, it doesn't always work for everyone. It was about who was performing the tasks in Wigan Council, who was carrying out the assessments and so on. Was it all clinicians or qualified staff, other staff?
Yeah. With BeWell, we are a physical activity and weight management provider through leisure services. So the instructors that work on active ageing are PSI qualified with a lot of other qualifications around physical activity. They have lots of years experience. During the lockdowns, we weren't furloughed and the team were redeployed, and most of the team were actually redeployed into reablement. So they've also been signed off competent in that low level equipment, and they are all signed off reablement officers as well. So that adds a bit of flexibility in the offer they can provide. yes, as I say, they've got lots of experience, but we do work very closely with the Falls team, with community therapy, with the social care teams. We're a very integrated approach in Wigan, and we are part of that Falls pathway. So if they have any concerns or need extra support, they can get that from a wider offer, which is great.
Thank you very much. We don't have any other questions, I think, posted in the chat, but I think one of the things that really comes out very strongly for me is just understanding those pathways and the links into other teams and the support that you can get from that. And I think really is, especially when we're thinking about how we put together these services, it would be really helpful sometimes to have some of these briefings available for people so that people can see how other places have done it. And I think that's one of the fantastic things of the collaboration that we have across Greater Manchester, is making sure that we can all share that good practice and understand how things link, because we all know as well that what works well in one area often needs tweaking to work in another. Has anyone, we're going to have all of the slides and everything will all be available afterwards, so don't worry, can't see any other questions, so I'm going to save time now by moving us on now to have more time for questions. So please think of your questions for the session at the end. But now can we turn on to Jason Bergen to talk to us about the delivery overview in Greater Manchester and how that's being supported.
I think we're going to have Lee first from Barry.
Oh, sorry.
Fine, it's fine, no worries, I'm here. Good morning everyone, my name's Lee Buggy, I'm the Principal Wellbeing Development Officer for Bury Council. I'm going to do this slightly differently in terms of what we just heard from Eleanor and build on some of that information. And probably cherry pick bits around what we're doing for as part of GM Active and part of the new integrated care systems as they're being developed locally as well. Our strength and balance pathway was kind of born from Eleanor's work in Wigan, but also collaboration with Dr. Holly Haig and Professor Chris Todd as well. So we picked up on some of that good practice. So rather than reinvent the wheel, we kind of cherry picked some of the best practice across Wigan and Oldham and Stockport, as we were kind of late coming to the table with Bury's strength and balance pathway. Ours was designed as part of transformational funding, so devolution from GM, and forming the referral pathway and criteria was a bit convoluted to start with, which I'll touch on in terms of the criteria of inclusion, just due to functionality, and we had to tweak that over several different periods working with partners as we're finding some inappropriate referrals were coming through. So we tweaked that over a period of probably 2.5 years now and got to a place where it's probably suitable and we're getting those outcomes that we want to achieve from what we're doing. Next slide, please. So this is the why, and unfortunately it's just cut off at the bottom. I don't know if everyone can see it. This came from Bury Council's performance support unit, and it depicts each pathway in terms of what it's costing our systems locally in Bury. I'm sure you'll have something, a data overview within your localities that pulls out this information, but it kind of teased out for us where the key elements of this particular burning platform lied, and how we needed to address these. As part of transformation, as I asked, we brought together something called a Falls Fractures Fragility Implementation Group. So it's called a FIG, essentially. So we brought together people from public health world, from health and social care. We had orthopedic geriatricians there. We had ourselves as leisure and wellness services. So we came together as a working group chaired by one of our local GPs with a real interest in falls prevention and strength and balance. And funnily enough, the key item that was mobilised first was the strength and balance programme, and that was via the advocacy of that orthopaedic geriatrician at North Manchester. So that's where it kind of was born from. So it was historical from what others were doing across GM, and picking up on that piece. And again, myself and Eleanor work as part of the GM Active Collaborative. We have had that conversation about bringing this to be equitable across GM, because we realise not everyone has a strength and balance pathway. So we're one of the lucky bearers to have that. So we were born from this costing millions of pounds in what we were doing. And that was the main driver for why we exist in our origin. Next slide, please.
And I'm my fault because we are going to have to hurry you along. That's so.
Yeah, that's no problem. So in terms of these, we built on our PSI and Otago program, very much what Eleanor said around home-based programs. They twin track and were co-delivered in association with community platforms. So we deliver our sessions within local leisure assets, but also in wider community venues. Home-based programs are then done within the home as well, and we take a variety of anthropometric measures and biometrical measures where they are suitable, and that's the key word. So we're getting this data, but we're very much working towards Chief Medical Officer's guidelines, as Professor Chris Todd spoke about earlier. So we're trying to work on this fluid basis around individuals and how we get the best results from what we do. So very much around what Eleanor said. Next slide, please. The pathway highlights, and I'll just cherry pick the three colours. One is around the home visit, so we go out and do that piece. We've integrated something around technology there and rewatching pre-recorded sessions. Home-based booklets go out, physical activity programs and diner bands are there and done in the home. And again, complemented to what we do with the orange pathway. So we did pre-COVID collect people in terms of transport and got people to sessions. There's some learning from that in that taxis didn't seem to work. Again, for a multiple set of reasons, which I think Cascade post this, but underpinning that and the universal offer in blue and green was very much around those classes that are delivered in our communities, but it's all done in terms of risk evaluation and best practice on who's delivering those sessions with what qualifications in what environment and how it's risk stratified. And again, I can pick up on that post this presentation. Next slide. So
we are very tight for time now, so if you just want to pick up the key points for the last couple of slides, all of the slides will be shared with everybody. Thanks very much. I am sorry.
There's no problem. So this one was just around our wider wellness offers and touching on the voluntary sector, how we're mobilising people into, put on the Woodies, Sporting Memories, Many Sheds, Knit and Natter groups. So again, it's not just around the prescripted evidence-based strength and balance piece, it's around the holistic approach that we're taking as well. So that was a key piece from that slide. And last one, I think, was it?
Fantastic, and I'm really sorry for having to rush you. And I'm going to go quickly on to Jason. Thank you very much indeed, because it's so interesting, so much stuff in there. Thank you very much indeed. Jason.
Okay, can you hear me? Thank you. Yeah, so I've met many of you. It's great to see so many people here today. I met many of you last summer when we were doing a mapping of strength and balance delivery and falls prevention services across Greater Manchester. And that fed into the Falls Prevention in Greater Manchester Delivering Integration and Reconditioning report, which one of the key recommendations was for this Falls Collaborative. So it's great to have this started in GM and soon to have a worker and funded post. But it was interesting, and you've just seen two areas that have good practice around delivering strength and balance in the FaME program, two of the components that they deliver well. All areas delivered in GM, which was great, but some in different ways, as has already been mentioned, some not following the full 24 weeks and have adapted it for different reasons, some doing different issues. And a lot of that was, I guess, linked to resource. And in many areas, falls services, there is a falls service. In some areas, it's more integrated. It's more of an everybody's business kind of model. In other areas, it's more clinical over community. And one of the desires, I think, from the research we did and from people we talked to was trying to integrate this more, and this was accepted by the Health and Social Care Partnership going forward into the integrated care service. And then on top of this, though, I ended up working with the university further on a new study that is an offer to Greater Manchester to support FaME to make it better, which we're going to talk more about and to deliver better outcomes and to see how it's being implemented and what works and in terms of good practice and how it can be adopted and implemented better. So the two components of that we're going to talk about now, and one is the National FaME Implementation Team, which is an offer to all 10 localities to get advice that Dawn will talk about and to deliver their program closer to the outcomes desired, and also the study that we're doing through the university called FLEXI, which is a falls exercise implementation research team, which Helen and I are part of, and Chris, that will also be offering a bit more structured research support but again, to all areas, and there will be an expression of interest for people to participate in both of these across GM. So that we'll talk about a bit more, and I'll keep it to that just so we have save some time.
Thank you very much indeed, and a really great offer of support there, which I know we're all, yeah, there it is. Yeah. We'll all be very pleased to take up. I'm now going to hand over to Professor Dawn Skelton, who to talk about the FaME programme support offer, and we're delighted to have Dawn back with us to talk about this.
Good morning, everybody. So I'm going to introduce NFIT, the National FaME Implementation Team, and our tagline is enabling older people to get up, stay up and live their best lives. So it's not just about preventing falls, it's managing falls as well, because we know although there's good evidence to reduce falls, sometimes people do still fall. We need to make sure they can get back up again. Next slide, please. So the FaME National Implementation Team is a mix of expertise to do with, first of all, the development of FaME in the first place with myself, but also the implementation of FaME. So we've got members from Agile, the older adult special interest group of the CSP, HUK, ROSPA, FaME services, near and wide, ones which have had successful long-term funding, good evaluation of their data and good pathways across systems. Next slide, please. So the main thing we can offer, and this is all completely free, is expert advice and mentorship. So whether you are starting up and want to start new FaME sessions, so how to get off to the best start and learn from others, or whether you want to ensure that your particular service hasn't gone off piste a little bit, because sometimes when you run something for long enough, you can lose a bit of focus. You perhaps haven't got the same rigor in ensuring fidelity. So expert advice and mentorship, online community of practice. This is not just for PSIs to share amongst each other. Often PSIs feel they're a bit of lone wolves because they've got their classes and they don't necessarily see each other. So the ability to share challenges and successes is really important. Quality improvement, and that's advice for internal quality improvement. Self-reflection, we have our PSIs have an own self-reflection tool where they can look and see if they feel they're following good practice, and of course advice on how to evaluate services as well. Next slide, please. We need FaME to be the best it can be. We know if it's delivered well and with fidelity, we'll get really good outcomes, but we need to ensure that we're getting our ideal return on investment. And there are some key elements of FaME that do tend to score lower when we go and do some observation visits. And those are things like home exercise, fear of overburdening participants, or maybe they won't come back if we work them too hard. And yet the importance of dose and the importance of them feeling improvement quickly should never be underestimated. Getting down and up off the floor. Again, sometimes this is concern from the instructor about will they get up again. It's class sizes. If there's too many people in a group, then nobody wants to be picked out at doing that floor work. It's also perhaps a mix of function in that group. Some people that you're nowhere near helping them to retrain that skill, and others which can do it easily. The behaviour change support, importance of phoning up if they miss a few sessions, getting them back in. We all know adherence to falls programs can be low because people do still fall and they're often carers for others as well. So that behaviour change support to reel them back in after lapses, and the social aspects of peer support, coping strategies that you learn from each other should never be underestimated. There are certain essentials. We know that it's important to have a PSI delivering it. We need assessment at point of entry so that we know they're right for those sessions, but also that potentially we can then tailor our group and individual home-based exercise program for those people. We know it should be 3 times a week, a mix of group and home. We know that QI and measurement strategies are important, but there's a lot of things that are adaptable and that we can potentially support you with, and NFIT could support you with. The use of circuits, formats, unison layouts, whether you're looking at a mix or a hybrid of virtual and face-to-face, various other delivery methods. So we're hoping we can help you with all of those sorts of things. Next slide, please. Remember, FaME is not just a set of exercises. The exercise bit actually is relatively easy. The rest of it, the bit about engaging somebody, ensuring that they change their behavior, that they understand the importance of being involved regularly throughout the week, not just turning up once a week for a class. Goal setting, self-monitoring, highlighting successes, all of these things are really important and make a program effective and change behavior, such that, let's face it, we need people to continue exercising for life, not just come for our 12-week, 24-week program. We need to change a whole self-management mindset. Next slide, please. So the observational visits that we would be able to do potentially as part of the FLEXI offer, which you're going to hear about in a minute, it's not an exam, it's not a tick list. Essentially, it's us to have a chance to talk one-to-one with the instructor and the team. Can we help? Can we improve? Can we help you get backward chaining or floor work back into the frame? Can we support you in engaging people in Tai Chi at the end, etc.? But also to help set up an internal QI practice, which then will just keep improving practice over time and potential local community of practice as well. Next slide, please. FaME has been shown to work in a variety of populations. I won't spend too long on this at all, but just to note that you've had FaME evidence in people that are falling 3 or more times in a year, up to those that perhaps only fall 20% of that population will fall. So we know that there's a mix of people in terms of multiple comorbidities, use of walking aids. We know it works, but not everybody in the same group. And what we have learned, particularly in rolling programs, is if you've got people that are very frail with people that are very fit, the very frail ones feel they're holding others back. The very fit ones feel they're not being pushed enough. And all of this is going to reduce your adherence. People will leave. So it is important to think about how you frame your groups. So there is some similarity, although individually you're still going to progress and move people along individually. So we can learn a lot for how we can deliver these rolling programs in that respect. Next slide, please. We want to update and build on the implementation toolkit. Things that we've just heard from Lee and from Eleanor, we can make a big input into improving how people monitor and evaluate their programs, build their case, but importantly, show return on investment. Last slide, please. So how does NFIT fit with FLEXI? You're going to hear a bit more about FLEXI now. That's the research offer for the Greater Manchester area, and also we're doing some in Devon. NFIT essentially is there for everybody. FLEXI will give a number of support options for a number of services in a bit more detail. And I'll pass you on to Helen to talk about that now.
Thank you very much indeed for a really, really interesting talk. Helen, are you going straight into this, or is there a video first?
No, I'm going straight in. So
excellent,
that's okay for time. So I'm going to talk to you about the Greater Manchester FLEXI study offer. So what are we offering? Well, and what is FLEXI? Well, over the next sort of 18 months, we'll be looking to support and carry out research across 3 to 5 different types of FaME delivery across Greater Manchester. We know that all of our GM10 areas are delivering something. So we're interested in working with a range of different providers and different areas. And also those who might be commissioning new FaME, or perhaps FaME classes in a new area or with a new population, wanting to improve fidelity to the existing FaME programs you've heard a bit about from Dawn, and also wanting to work with those hardest to reach. So we're really interested in people interested or already working with marginalised or seldom heard groups, and perhaps those areas with high levels of poverty and fewer services as well. Next slide, please. So what are our research questions, I guess? So we want to know what works to foster the adoption of FaME and what role the implementation toolkit actually played. We want to do a comparison of Devon and Greater Manchester and how things are adopted, FaME is adopted. We want to look about what delivery looks like in real life and how much it actually costs in the real world. So what are our outcomes? Who are we reaching? How do we make adaptations? And we also, as Dawn's talked about in detail, want to look at fidelity. So how do we understand support and improvement and continue to provide long-term support? I'm just going to get to that. I've just seen a comment asking how this differs. So next slide, please. So basically, we would look at all areas we're able to access NFIT. But on top of that, we would offer through the FLEXI study, the later life training observation visits would be fully funded because we would be using information from that as part of the research. We would also, rather than just give advice on the evaluation of your service, actually look at doing cost analysis and analysis on your data. So we'll give you feedback on participant outcomes, for example. Next slide, please. We would also be asking for things from you. So NFIT's offer mostly is how they can support you to do things. Because it's part of a research study, we would be asking for things back to you, from you, but that's so that we can help you. So we would be asking for anonymized demographic and participant outcome data. And we would give advice and support on how to set this up. We would ask for access to FaME classes. So we would ask that we come and do some observational visits, and that would be done by later life training. We would also ask for costs. So if you could share costs about the costs of delivering and implementing FaME in your locality. And we would also ask for help facilitate our access to a wide range of stakeholders. So that might be participants in your classes, your exercise instructors, commissioners, and different stakeholders. Next slide, please. And so just so this is a project that is across Nottingham, Manchester, Exeter, and has multiple partners involved as well. So I think that's my bit, and we're going to play another video, and then we've got some questions and answers.
Thank you. Thank you very much.
The course was recommended by my young doctor because I'd gone up again about a fall I'd had, and he said he'd heard about this and he would try and get me on it, which he did, and the course was absolutely everything I could have wanted at that stage. The course has helped me in so many ways because you are advised to do the exercises at home. They only ask you to do them about 3 times a week, but I did them more because I had more time on my hands, and they built them up. You didn't get them all at one go. You started slowly, and then the next week you'd learn something else. And so you weren't bombarded, you just gradually got to the stage where you could do most things. We got a video, and we always got books, different books, but you had to do them at home, starting with 5, do the same thing 5 times, and then work it up to 10 when you could do. But it were only things that you had done at the course. Like when you stood at the sink, you can do some of the things there while you're doing your vegetables and things. Make it an everyday thing that you are doing, not just something that you're purposely having to do it. The course, I can't praise it enough because I have learned to do so much for myself, to be independent. I can walk on a brand new knee on the floor for 5 steps and back, and like this week I had to kneel down on it because I read my own electric and gas meters. I can pick myself up off the floor. I know how to do all this, and particularly to get out of bed. I can't say how many things in the house these exercises do help you with. They come into everyday things that you do. The class has made me independent. I've no family near, so I'm solely on my own. So if I fall, I get myself up, as I've been trained to do. So when I go out, I make sure I go up this hill, which puts is very hilly, and just do it. But I wouldn't have been able to do that if I hadn't have been on the course. I'd have been too frightened to have gone out. So this is how it's helped me.
And that just summarises everything, doesn't it? Why it's so important that that person had been frightened to go out and now she's going out because she can do that. So she's got a purpose. Fantastic video. Thank you very much. We're now going into the question and answer session. So I think we have Helen, Dawn and Chris answering your questions. And I think the first one is for Dawn. And we've had a question from Charlotte, which I will now try and find again, which is about, does this system work? Have you been able to test it with people living with dementia or with other cognitive impairments?
Okay, so there has, starting off with other potential cognitive impairments, there is actually a research publication looking at FaME delivered with adults with learning disabilities, and it reduced falls and improved balance and function in them in Glasgow. In terms of cognitive problems and dementia, there's not been a research publication with it, no, but I am aware of many services that run specific classes for people with early dementia, early diagnosed dementia, and also two down around the Cambridge area that work with people with quite severe dementia in much smaller groups. So they only have 3 or 4 people in a group and the carers are with them.
Thank you very much. And imagine in care, I think there is quite a lot that's done in care homes as well, isn't there, specifically for older people? Yeah.
Well, interestingly, when I first developed FaME, and actually just before I'd published it, before I came up to Manchester, I left academia for a little while and I set up the first exercise fall service in Merton, Sutton and Wandsworth. And we went into care homes there and I actually delivered the classes. And we got some fabulous feedback, people going from walking in or actually being wheeled in with oxygen attached to their wheelchairs, and by the end of the 6-month program, because we ran it for 6 months in the care homes at that point, people were walking in with a stick without oxygen. Honestly, it was fabulous. There's huge changes you can see, but again, the groups are much smaller and you need a lot of helpers, because you need people to be supportive around, because if someone's very frail, obviously you've got a worry that you want to challenge them in standing as much as possible, but they get tired very easily. So to have staff around to help makes a big difference.
That a really important point, and thank you for that, and Dawn, fabulous results.
I was just saying, you mentioned the fact that we often have the carers of the older people who've got dementia, people living with dementia are there, and presumably by the carers you mean their next of kin or older person, family members who are themselves probably going to benefit.
Absolutely, and in fact there is plenty of research to suggest that sadly a lot of people can't carry on in formal caring because they start having falls, and so to involve them in many of these sessions would be very useful.
I think that is a really important thing that we could possibly also bring back to general practice and carer centres and carers assessments, because really that carers assessment of their falls and the likelihood of their falling, and getting GPs to promote falls prevention with that group could be really beneficial. We've got another question, which is, can any of the parts of FaME or FIT be done remotely via video calling? Right. I think probably we're trying to get people out of the home, aren't they? But it would be useful to have your views on that.
Obviously during COVID, some people did do that, but not many, through fear of somebody having a fall at home without anyone being there to help. But there is absolutely no reason why we shouldn't consider the use of remote and digital technologies to support dose. It would be really good always to have some face-to-face to know that somebody is got the right technique and is safe and understanding the instructions, etc., and then top it up by a home-based. Certainly for those who are more rural and have got transport issues, that may well be the case. The other part, NFIT, is all about advice and mentorship, and we can do that, and that's the service and to PSIs, and we can do most of that remotely.
Brilliant, thank you. And just to remind everybody again, it's in the chat, but there's a month to do, and if you're interested in being involved, there's an expression of interest form which will be being sent out to everybody. You need to get that back, I think, within a month. So I know there is quite a tight deadline on it, but Jason will be able to support people with doing this. But I think the fact that we've got over 100 people on the call is just such a fantastic. I think you're going to be somewhat overwhelmed, Jason, which is great.
We hope so.
And somebody's pointed out the need to link in with social prescribing with this, and I think that's another really good idea. Have we got any more questions? Can I sneak in a question? Chair's privilege, which is really thinking about how we involve, and I'm sure you've done this already, but thinking about the relationship with the Integrated Care Board that's being established across Greater Manchester, and using their offices, particularly around some of the return on investment, and really seeing if we can get any of that Integrated Care Board. They're holding a lot of the purse strings for this. How do we make sure that this is coming into the into these programs? Question for any of you, really.
So does anybody know who holds the functional decision maps for the Integrated Care Board at this point? Because that's the place to aim at, isn't it? They're not in the public domain at the moment, as far as we know. And we are completely with you that, yeah, we recognise this as very important. I understand that that's all been pushed back until at least July now.
It is.
Possibly later. Yeah. So it's still in the House of Lords. So. Yeah. Yes.
So it won't start before July, but I think the more, I mean, certainly I'm very happy to take this back into the public health field and make sure that we raise it and try and think how we do this outside this meeting. I don't want to take too much time of this meeting, but Chris, you and I will pick this up.
And I think that we've had a lot of conversations with Warren, for example, already, and we know that this is right up the agenda. So Greater Manchester is taking this very seriously, falls prevention. So I'd like to say we're pushing at an open door here.
I think so. I hope so. But let's keep making sure it stays open, and money comes out of the door.
Yeah. Can I add that, just to make clear, and I'm sure that this offer is available to commissioners as well. So this expression of interest, we're looking for you know, obviously providers, postural stability instructors. We are looking for commissioners to hopefully engage with us as well, and we're also offering that support to commissioners as well as providers. And also, just to add, I think the expression of interest is just over a page, so it's not too arduous, we hope.
Thank you. That is very good news. And we've had a question about whether Health Innovation Manchester are involved in this work.
Going to let Chris answer that one.
I was still on mute. At an early stage, I was trying to get off of mute. At an early stage, we've been talking with Health Innovation Manchester, who we were hoping would help us roll this out across Greater Manchester, but the prioritisation of things related to COVID has got in the way here. So that's hence we're doing this today. So this is, you know, we've got the support, but not the clout of Health Innovation Manchester, because they're looking at something else at the moment. So does that answer the question?
We've also had an offer from Greater Manchester Active to help disseminate information. So I think we've got a few routes. We've got 1 minute left. I think this has been a fantastic session. I think you know, in an hour, we've covered an amazing amount of ground. I want to very much thank our speakers, all of our speakers, and thank everybody for attending. Thank everybody for contributing. And there's a brief feedback question to send in. Please do put in your expression of interest, and I'm sure this is going to, as people have said, it's been far too much to take in for 1 hour, but I think this enthusiasm will mean that we'll definitely be running this sort of session again, and thank you very much to Chris, Dawn and the team for putting this together for us.
We'd be very happy to run it again and do it slower, but we thought it really important to get people here and to ask you to come for half a day. We understand everyone's schedules are very full. Yeah. Thanks very much.
Thanks very much. Great. Thank you to everyone.